Yeah, I have two kids, one in high school, one in college. They're both very active, good kids. Very proud of them. Lately, I've been working in the ER and suffering the consequences of that, like most people would.
Are you on a night shift rotation right now?
No, how my month goes is I kind of circulate, so all of our partners will work some early mornings, then late mornings, afternoons, swings, and then nights, and then you get a block of time off and come back for more.
Yeah.
So lately, I just did a swing shift, which which about got me.
Yeah.
I was I
I know
was
that we all
thinking,
avoid Dr. Dirk
yeah.
when he's working night.
No, no, I'm not mean.
No, he's not
No,
mean.
I was just typing my resignation letter during the shift in my head.
I bet you were.
Yeah.
You were like, I could chat GPT this, make it a
Oh,
lot easier.
very, very easy.
Yeah.
Type an angry letter. No. All right. So it looks like we're live on YouTube and Facebook now. That's
All right.
exciting.
Heck yeah.
I don't think I've ever been live on YouTube
You're a big deal now.
or
We're
Facebook.
streaming on multiple
Well, this is a good
platforms.
test. So we're doing a test to see how this goes.
Yeah. And if anyone in the chat has any questions for Dr. Dirks, he'll go over his background here in a second. But feel free to drop those. We've got myself as a moderator, and then our lovely moderator Eli, aka Hawk's Nest, look him up,
Nice.
is in the background doing some moderation too. So feel free to drop questions if you've got EMS related questions you wanted to get into EMS or have questions about it, or if you are looking at medical school or something like that. Dr. Dirks is all ears, ready to answer your questions. So
Yeah.
we will start with what is your medical background?
So I went to college in South Dakota as a biology major, which a lot of physicians do, but you don't have to be any type of specific major to go into med school. And then immediately after college, I went into med school in South Dakota. I started there for 2 years. Got married to a lovely lady, Karina, who was a med student in Nebraska. And I, out of love, you do crazy things, I transferred med schools, which is frankly insane. And just to tell you how that went for me, when you transfer med schools from an in-state med school to an out-of-state med school, they make you pay for it, literally. So I paid through the nose, came out of med school with plenty of debt.
Extra debt.
Oh, not just extra, a lot of extra debt. So graduated from the University of Nebraska Medical Center, and after 4 years, and then stuck around there to do an emergency department fellowship, or not fellowship, but residency. That's another 3 years. ER residency is 3 to 5 years, but should generally be three. And then left residency and moved out to Spokane, Washington, which is where we are now.
Yeah. Beautiful.
And I've been an ER doctor since 2008.
And did the job bring you here?
Yeah, no, so when we were looking for places to move and settle down and kind of start our careers, we looked all over the US. We had no family out here and just liked the area. It's beautiful. If you've never been to Spokane, it's a lovely town. Beautiful. In the Northwest is gorgeous. The weather but when we moved here was really quite lovely. And summers have gotten a little warm and a lot of smoke with the forest fires. But winters, yeah, again, lovely place to live. So yeah, it's where we've been and working in the emergency department since.
Yeah. And then what about your role here at EMSConnect? Obviously, this whole thing is
Yeah,
about EMSConnect at its core, right?
kind of
So
strange. So how this all came about was I had no EMS training. And when I moved here and started emergency medicine, one of my mentors, Dr. Jim Nania, who's currently the Spokane County Medical Program Director, encouraged me. I was young and I had some energy still. I was a little crazy. So he encouraged me that I should get into doing some EMS advising for local rural fire departments who needed help. I got into that, started meeting with one, two, then took on a third. I was getting pretty burnt out with just traveling and education. And so I had to turn down other ones that were asking me to come help them out. I felt really guilty turning them down. And so then it kind of hit me all of a sudden of like, I don't need to travel to them. Let's have them come to us. Because I had friends around the country, other ER physicians, EMS physician colleagues. And so started EMS Connect and kind of the snowball started rolling down the hill pretty quickly from there. And we branched into other states, became nationally accredited with CAPCE and started building.
yeah, and you started your first ever like thing in a boiler room. Is that what you said?
Oh, good trivia question.
Yes.
Yes, so the
People want to
first
remember.
ever EMS Connect episode was live from my furnace room. I, put up some walls and painted them, had my computer down there because I had little kids at the time and we were doing it late in the evening during training hours. And yeah, so we were doing it live from a furnace room. It was just me and a computer. It was pretty scary.
That's crazy. And to look at us now, I mean, you've got
Oh, it's nuts, yeah.
users. We've got users all
Yeah.
over the U.S.
Yeah.
Always getting asked to expand into other countries, and
Oh yeah, we've done live sessions with Afghanistan. We've had active military in Afghanistan who've played live with us, like during an evening session because it was, middle of the afternoon there or something. We currently have fire educators in the UK who do recoil upbringing where they could just send me wherever. And so I went to college in South Dakota to a small liberal arts school there, and they had a great biology program. So I was in biology, doing my thing, still thinking like I want to go to the ocean, and just naturally went down this biology path to it's way more logical. Like human stuff was intriguing to me. It was fascinating biology stuff, so I stuck with that. And I had an older brother, 5 years older than I, who was quite smart, and he was going into medicine. He went into med school, and it just was a very natural progression for me, still being into biology. And so I went to med school, and then never looked back. Still think about the ocean every day, though.
oh, me too.
Yeah. Every day.
Sun on your skin,
It's the water.
salt.
I don't even stay in the beach. I'm in the water the entire
Yeah,
time. I
there's
just
nothing
float.
Like, it's like being in the womb.
Yeah,
I think that's
yeah.
what they
Oh,
say, though.
that's what I told my wife the other day.
Especially the warm ocean. You go
Yeah.
like nice tropical.
And being weightless. So I'm a scuba diver. And so being, 30, 60 feet down, weightless, it's the most relaxed I've ever been in my life. It's paradise. It's great.
It's like it's where we're meant to be.
Absolutely.
And then we do have some new viewers, possibly. A lot of our friends here on the TikTok, they know us, they know what we're
Yeah.
about. But we also have viewers on the other apps, which I won't say because we'll get in trouble.
Oh, sure,
if we go on
sure.
TikTok.
No
But,
problem.
Other apps joining us. Do you want to talk about EMSConnect? Like, what is it?
Absolutely. So it's a pretty simple system. It's basically a learning management system, all encompassing, where we do every month there will be a live session guaranteed, and that's our new content. It's going to be for all levels, BLS to ALS, even critical care. And the purpose of the live session is to bring you education for all levels, to bring you up to speed, to refresh if you're a paramedic or critical care. With it, there's a test you can take afterwards. If you can't participate live, we do edit it, put it in the archive and the catalog so that you can complete your CE online. Everything we do is CAPCE-accredited so that if you are an NREMT provider in the States, everything we do you can use towards recertification. If you're simply a state provider, all of our stuff should be able to be used at your state level because we're actually already nationally accredited. To that degree, our catalog also includes monthly BLS content, critical care content, extra content we do for some state certifications like bloodborne pathogens or driver training. We also offer fire training every month, along with we're getting into nursing stuff now as well. And so really the goal is to bring you extremely affordable education that meets all of your mandated national criteria. And for those who are on other resources, you can see kind of our catalog anytime you want. You just go to emsconnect.org, click on catalog, and you can see all of our current content. Our catalog will be full of 3 years of content, and that's per CAPCE allowances. After 3 years, you have to remove it for the EMS side. We're getting into a lot more critical care stuff and the nursing stuff. But the point is to bring you very affordable, easy to use CE that you can use from anywhere in the world, on your phone, desktop, anytime, anywhere, at your convenience, unlimited. As an ER physician and with all of our staff being EMS related, we don't do BS at all. So the goal is that you can go on anytime, complete as much or as little CE as you want for a flat fee. And as long as you're happy, we're happy, and there's no contracts, no extra fees, no cancellation stuff.
And I think I can speak for everyone in EMS when I say that we love affordable and we love easy. So.
And I love no bullshit.
Yeah.
Yeah.
Yeah, we love that too.
Yeah.
We do. Yeah. Okay, so if you weren't an ER doctor, what would you be doing then? Scuba diving?
Yeah, I mean, if you have to make a living, I'd probably try to make some sort of living off ocean stuff, but you got to be an adult, and so you get married, you have kids. I would do whatever it takes to make enough wages to just be a good dad. Yeah, it doesn't matter anymore because go to the hospital, you're working a night shift, and I can call out myself of being kind of a POS because I'll work a night shift and I'll get all miffed and angry about certain patient cases, or I'm tired, and then I look over and there's, custodial staff cleaning the floor at 3 a.m., just like I'm working. And so absolutely, I think, can't complain.
Yeah. Okay, so we'll dive into some doctor questions. That's
Sure.
what I titled this. What's the biggest mistake that you see EMS crews make before they get to the ER?
Anchoring bias is a big one that kind of jumps to the top of my mind. And that's something that ER physicians and everybody does, nursing, EMS, it's just a natural human reaction. The anchoring bias is basically you walk into a room or you come on scene and you see the patient or you hear a few words, you do your exam, and you immediately think, oh, this is what this is.
Yeah.
And you anchor to that thought, and it's just immovable. And so even when you find other data points or other historical elements that would point to you're wrong and it's this, you don't move off that initial anchor.
So it's like tunnel vision, right?
Bingo.
Yeah.
It's exactly
Okay.
what it is. Yeah.
Yeah.
And so I see that, and in doing that, they'll kind of talk themselves out of what they should do. So I'll see people who maybe didn't intubate the patient, even though they knew that this is the right thing to do next because I'm still anchored to it. It's just an opiate overdose, and I'm going to give enough Narcan, and it'll reverse it. 16 milligrams of Narcan later, the patient's still obtunded and not breathing, and you kind of go, change. You just
Time to
go
change
down a
course.
different pathway.
Yeah. Okay, I put this question in here because I'm super excited to hear you answer this. If ER physicians had Yelp reviews, what would yours say?
I do have a
I
review
know
of
you
it.
do.
So I think the last time I looked at mine, I was like rated 2 out of 5 stars, which is an improvement from the last I checked it. And it said I was a female physician who they were really upset because I didn't give them the medication they wanted when they came to the ER and expected me to give them. So I think we're all in the business in EMS and ER of we're dealing with people on their worst days, right?
Yeah.
And some of those people are having a really bad day and there's nothing you can do that's going to make things better. They're not going to like give you a 5-star review as they were suffering with a broken femur, unless you really knock it out of the park. And so we try to do the best you can. You have compassion, you give them pain meds, and you do the things you can. But I gave up trying to satisfy people a long time ago.
Yeah.
Yeah. Just do the job that you're trained to do to the best you can. You can't ask for any better.
And your wife is a physician in the ER as well with children.
No, so
Or
she's
she's a pediatric
she's an
hospitalist.
inpatient pediatric hospitalist.
yeah.
So she only takes care of the kids who are admitted
Right.
on the pediatric floor. I mean, she's like an angel compared to me because like she works with the patient who's a child and the second patient who's the family,
Right.
right? And the family can be horrendous.
They can be the worst
Oh,
patient.
good gracious. Yeah, the stories. But I'm in a fortunate role where I deal with adults. I don't even do pediatric ER anymore because I couldn't do it anymore. I felt bad for the kids. I wanted to stab patients or parents in the face. It got bad. I don't like bad humans. But adults I can deal with.
Yeah.
Because if adults making a bad choice, I can be very honest with them and tell them what I think in a very loving way.
Yeah.
It's
Absolutely.
like difficult parenting, right?
Do you think that your wife has better Yelp reviews than you do?
Absolutely. Oh gosh, yes. She's a sweet person. Yeah.
I would like to see them side by side. Just
Oh,
to
I can tell
compare
you they're
notes.
vastly different.
Yeah. We'll lead into what's the most ridiculous excuse that you've ever heard from a patient?
For like needing stuff they
Just
don't need.
any sort of you could go
Well,
down
people
that route.
lie to us all the time, right? Again, it's their worst day. Sometimes it's their most embarrassing day. And you'll ask them, how did this injury happen, or how did this object get into your rectum? And you'll get a story, and you just know it's BS, but it really doesn't matter.
Yeah,
Yeah,
because it's
but-
all about how to fix it, right?
Yeah, well, they don't want to get in trouble. And it's kind of like a parenting thing where I think they know as an ER physician, I'm not going to call the cops on them if they did something naughty. I'm not going to immediately call their spouse or their boss. But it's just that human condition of like, I'm embarrassed by what I did or what happened to me.
Yeah.
And so you'll ask them, how did you crash your motorcycle? And they're, twitching and doing all sorts of crazy stuff with a heart rate of 150 and their eyes are dilated. And they're on a stimulant, like it's obvious, okay? Or you can smell the alcohol in their breath and it's pungent alcohol and they're totally wasted. And they try to talk to you like they're not wasted. Or explain to you like, I never drank. I haven't drank in 3 days. And so that's always entertaining.
Yeah, and it's they never understand. I'm not the cops.
Correct.
Yeah.
Yeah, they
Just
think
tell
they're
me
going to
what
get in
you
trouble.
did.
Yeah.
Yeah.
And that's frustrating sometimes as a provider, and I'm sure EMS sees this too, of like, you just want the honest truth so then you can diagnose and treat them appropriately
Yeah.
instead of wasting your time trying to figure it out on your own.
Yeah.
So that gets frustrating.
And I'm sure you've heard some things about some things people have done to themselves and just situations they've got themselves in.
Yeah, and usually, drugs, alcohol, or anything embarrassing, they'll try to fib just like any kid would,
Yeah.
right?
And I think all of us can say that we're not liars, but in that position, I probably would fib too about how I got
People
into that
don't want to
predicament.
admit, especially, you think about the environment too, like in EMS, it's never just like you're with one EMS provider. There's a team or a mutual aid, and like the fire department's here, the EMS is here, the other fire district showed up. You got 6 people listening to your private story.
Yeah.
Well, I don't expect people to be honest in that regard. Same in the ER. You're in a big lit up room with 6 people. Yeah.
Yeah.
I don't expect to get the truth.
Yeah.
Yeah.
We do have a question from TikTok. The Hotshot123 says, I have a question. Do you have bad dreams or flashbacks about the things that you've seen?
I used to, regarding stuff that really bothered me. So one thing that really got to me and why I stopped doing pediatric emergency medicine is I was having a hard time dealing with seeing kids that were abused, whereas my wife can deal with that really well, and she doesn't bring it home at all. I was not happy with that. I felt very protective and somewhat violent towards the abuser. And so, yeah, it finally hit me of like, I don't think I can keep doing this. There are better people who can deal with kids and keep their stuff together. And I'm eventually going to probably hurt somebody's abuser. So I had to get out of pediatric emergency medicine. It was just bothering me too much. And now I just do adult, which I can handle no problem any day, anytime, no matter what happens. So I used to have dreams of stuff. However, now as a parent, I think I'm more likely to dream about stuff I'm worried about with my own kids.
With your own kids.
Mhm.
Sure.
Like I have teenagers who are driving. There's plenty to worry about, right? Yeah.
And one teenager driving in a very populated city.
Yeah.
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 Let's see here. What's the most impressive save that you've ever seen that started with great pre-hospital care?
That would have to be kind of your stereotypical gunshot wound or stab wound. I think the stab wound in training, I was in residency. EMS was bringing in a stab wound single to the chest. And they still had pulses. They were intubating. They were just killing it, right? Doing all the stuff they're supposed to. Rapid transport, knowing he needed blood. It's a penetrating trauma. And so they did everything they're supposed to, intubated, fluids. They didn't have blood available, but they got him there quickly. We rolled him in the ER, and this is back at a level 1 trauma center in training in Omaha, Nebraska. And so we had a full trauma team ready to go. And we had right when he rolled in, he lost pulses, which is one of the indications then with penetrating chest trauma. If they lose pulses, in the ambulance bay or in the ER, you can crack their chest and do what's called thoracotomy. And so we had this person's chest opened up within minutes, exposed lungs, exposed heart. We had found the little hole in the front part of the heart from the stab wound, and a stab wound is potentially more likely to survive because it's usually one puncture, not through and through like a bullet wound would be. And so we found the hole, and I put a finger in it, and so we could keep resuscitating with blood. At that point, we're already massive transfusion, blood for this guy. And I remember the trauma surgeon, I said like, I think I found the hole, and I had my gloved finger in it to keep it corked until we could close it. And the trauma surgeon said, are you sure that's it? And I took my finger out of it, and because it's the heart pumping, the heart shot blood and hit the ceiling, like a 10-foot high ceiling. And I was like, and I put my finger in, and I'm like, yeah, I'm pretty sure we got the right hole. And so then he, took care of it, closed the hole as best they could, rapid to the OR, and the person lived amazingly, which is super rare, right?
Yeah.
To get a penetrating heart wound and survive it is pretty rare. So those are those kind of golden moments. You're like, oh, we actually do amazing stuff sometimes, yeah.
One thing I've always wondered is, do you recommend that bystanders, even no matter your level of care, if there's a hole and things are bleeding, do you put your finger, your hand, whatever in and try to stop whatever is?
Direct pressure is usually the key. So
Right.
typically you don't have to put anything in the wound, but so if you can just take a pack of 4x4 gauze or some acrylics wrap and just shove it on the wound and push hard, almost to the point it's painful. I mean, really, a direct pressure should be uncomfortable. And do a pressure wrap or something. If that works and the bleeding stops, great, you're good. If a pressure dressing is not quite doing it because of the position or where it's at, or you can't get a good pressure on it, putting a gloved finger in the hole, or two or even three fingers to try to get direct
Press.
pressure right on the source of bleeding is perfectly fine. Yeah.
Let's see. What's something EMS worries about that ER doctors usually aren't concerned about? Just something EMS worries about that you're really not concerned about.
That's tough because I'm in a very privileged position of EMS shows up on scene and they don't know what they're walking into, right? Nothing. They have no idea, and half the time the patch is completely inaccurate because it's bystander report or some, drunk friend. And so EMS is really in the bad position on this. They're disadvantaged because they walk into a scene not knowing what's going on, and then they do all their stuff, and by the time they bring it to me, I mean, they've done half the work for me already, which is like super nice, right? They already know half the history. They've had some time. They had an exam. So by the time they get them to me, most of the history and stuff is kind of known. But inevitably, it's just like being a med student. EMS will sometimes bring a patient to me and they'll stay in the room while I'm getting my initial history. And then the patient treats me differently because they know that I'm the doctor. And so now they give all the real facts, whereas they didn't give all the real facts to EMS. And so EMS, you can just kind of see their eyes of like, dude, what the hell?
Yeah.
Like, come on. You could have told us this, not made us look bad in front of the doc. But I never blame them for that because it happened to me as a med student all the time. You walk in and you say, I'm a med student. The patient inevitably immediately treats you like you're a child, or like, oh, you're not the important one. So I'm going to not give you all the information. You don't need to know. And so then the doc walks in and they give him everything. You're like, dude, come on, like throw a guy a bone here.
I think that's a good thing for EMS providers to realize is
Is
that
that if the patient didn't tell you, it's not your fault.
Oh, no, no. If you ask the questions and they withhold it, you don't have to feel bad about
Yeah.
that.
What's a patient complaint that you never take lightly?
I don't like it when people say we're not compassionate. So I think this is where the public gets really confused. And we did a podcast or session on this not long ago, the difference between compassion and empathy. And so where the lay public goes horribly wrong here is they expect doctors, nurses, and EMS providers to be empathetic, meaning whatever is bothering me as a patient, you should care a lot about it, and you should like come into my suffering with me, and we should ease through this together, and you should care a lot, right? And so they have this perception that like our job is to just cater to whatever's bothering them. Well, if what's bothering you is like, well, it's Saturday night, I can't call my doctor and I want a refill of my controlled opiate medication because I've been taking more than I'm supposed to, knowing that I was doing the wrong thing, and I knew that if I ran out on a Saturday, I'd just come into the ER and you'd give it to me. I'm going to disappoint you. You're going to rate me 1 star out of 5, if that, right? But this is where the compassion empathy problem happens is people will come in and they're suffering, they have a kidney stone or a heart attack and they're in pain. I don't want to walk through that suffering with you. My job is to be your doctor. EMS is to like fix you up, stabilize you, bring you to me. My job is to diagnose the problem and fix it as best I can while making you as comfortable as I possibly can while keeping things safe. Outside that, people probably perceive some of us as cold and robotic because they expect us to like come in and hug them and give all this loving sweet care and go get your warm blanket and your pillow, whereas I've got 8 other people who are actively trying to die, and I've got a little bit of time to evaluate you and see what's going on and then fix you as best I can. And so people confuse caregiver and doctor a lot, and they expect this loving, cuddly parental caregiver. And what they get is, a 2 a.m. ER physician who's having their ass handed to them, who just needs to like get you taken care of, keep you alive, move to the next room, and stabilize the septic dying patient. So it's not uncommon for me to walk into a room, it just happened last week, and the sweet elderly lady who had waited like 9 hours in the waiting room, 9 hours because their primary care provider didn't have time to fit them in the schedule that day, dumped them in the ER and said, well, you should just go to the ER and get this evaluated. Well, they didn't call in to see what the wait time is, what the waiting room is. I didn't expect that. But I also don't expect primary providers, urgent care providers, chiropractics to just default send everybody to the ER. That's just rude, right? It's bad for them. It's bad for us. It's bad for the system. So I walk in, and this sweet elderly lady is sitting on the bed looking as annoyed as hell, right? And I didn't know she'd been waiting 9 hours. And I walk in, I'm like, "Hi, I'm Dr. Dirks. What can I do for you?" "Well, first of all, I've been waiting 9 hours." I go, "Okay, I'm not going to say I'm sorry. It's not my fault." And so I sit down, I'm like, "Well, what brings you in? Let's talk about this." And she kept coming back to how annoyed she was for waiting, and she was there for a non-emergent complaint. And so I tried to be as understanding of the situation as possible. It sucks for her, but at the same time, she's not dying. And what sadly I can't tell her or do is I want to take this patient, take their hand, walk them down the hall to the room I just came out of, and show them the dead body that I just tried to resuscitate for 40 minutes and had to go talk with the family, explain to the kids that the dad's going to look different and there's tubes coming out of dad and dad's dead. And this sweet old lady is just, "I've been waiting 9 hours." So there's this complete disconnect of like, what the hell are we doing? When I'm not in your room, I'm not sitting in the back with my feet up watching YouTube, eating a cookie. I'm trying to do.
Never happens at work.
Right.
I barely have time to take a piss,
Yeah.
right? Yeah, yeah. And so we're eating on the fly. We're trying to keep people alive. We're in an environment just like EMS of like, you're doing more with less. There's less providers out there. There's less ambulances, but yet more EMS calls. We're all overworked and strained, and the lay public just doesn't get it.
I was gonna say,
What is something that you could tell the public about the emergency room? How do you explain to people gently what the emergency room is
Great
for?
lead in. Yeah, so a lot of what I do is try to provide patient education of, I know you're upset you've been waiting 9 hours, but here's the difference between the outpatient world and the ER world is, what's an emergency? So I find myself a lot on shift these days trying to get people to grasp the concept of come to the realization of what brought you in today, your back pain that's been going on for 6 months. And you came in tonight on a Friday night at 1 a.m. because you're just tired of it. Is that an emergency? Is this a life-threatening emergency that you need to take an ambulance to an emergency room? Like, the things that are taking an ambulance to an emergency room are the heart attack who's actively dying, the septic patient who's actively dying, the acute stroke who needs medicine right now. Those are the people who need an ER. The broken leg, the nail through the head. That's an ER. That's an emergency. And so it's this total disconnect. Like, humans have lost the concept of what an emergency is because everything has become so dramatic, right? Everything's on my phone. Look at me and the drama. And they've just totally lost contact with reality of what's an emergency or not. And then they get mad at us when they come to an emergency room and they keep getting pushed back in the line, and the people who are sick and dying get pushed to the front. And it's like they don't get it. Yeah.
Yeah, I completely
Yeah.
agree with you.
Yeah.
That's
Yeah.
something I think EMS can attest to is the amount of patients that you take to the hospital who never
it's
needed to go
frightening,
in the
right?
first place.
And that you talk about burnout, like what's burning me out and you and all these EMS providers is if we were running calls on emergencies, this is a very rewarding career.
Yeah.
It feels good. Like the other day, I was working a shift with another physician. We're both burning out a little bit, and it's just patient after patient who shouldn't be there. And then we finally get this horrible level 1 trauma activation, motorcycle crash, body parts everywhere kind of thing. People about died. And we came out of that, and the charge nurse actually apologized, said, "Oh, I'm sorry. I know this is a rough night. That was a rough case." And we both looked at her and said, like, "Are you kidding me? That was the best case all night. I feel better again. I feel like an ER doctor."
I feel like I made a difference.
Yeah, like I actually did an emergency thing I was trained to do. And then you walk into the next room and get yelled at because they waited 2 hours for their, toe sprain. Yeah.
What percentage on like an average day for you, what percentage of the cases that you see are actually emergencies?
Well, I'm fortunate that I work at a trauma center. So yeah, so a regional trauma center, which we do cardiac, stroke, trauma. And so I'm in the acute zone. So how our ER is staffed is our emergency physician trained providers work in the acute zone. So all we see the entire shift is just a hammering of generally the patients who are the sickest. And then, some people get mixed into that based on just flow. And so I would say where I am, 50% of what I see during a shift is pretty sick or gets admitted.
And that's probably higher than
That's
Some
super high,
doctors and some
super high.
hospitals, yeah.
Yeah, for an ER, generally like a high acuity is like 20%, where we are, it's just where we get
Just with the
so many.
summer, I mean, we
Oh,
see so many.
yeah.
Fatalities on the motorcycles and
Sepsis is just rampant.
yeah.
The elderly population, sepsis is there. And then when you start doing, if your town has a high homeless population, drug use, the infections are pretty heavy, that kind of thing. Yeah.
Yeah. The hotshot 123 asks another question. He says, if you have a heart murmur and you get, and I can't say this word, so I'm going to do the action, but like, repeatedly poked over and over, or bang, bang.
Yeah.
Okay. So, in the heart, what will happen if they have a heart murmur and that happens to them? Does that affect care?
No, no, the heart murmur can be from various things. I mean, usually it's just from abnormal blood flow through a valve or leaking through a valve going in reverse. So it really depends on what the first cause of the murmur is. But if you're injured in any way, the original cause of that murmur shouldn't be specifically a problem. The major thing is if you're losing blood and you just need blood. Yeah.
This is just a fun question here too. What's something that looks scary but usually isn't?
Oh, that's a great question. I would say the open fractures look horrific,
Yeah.
right? Like a trauma, car crash, motorcycles, or just, fall off the trampoline. You got bones sticking out of the leg, poking tibia here and there's blood, but they're almost never hemorrhaging. The blood is just this oozing venous blood.
Especially the lower leg.
Yeah, and so like I think open ankle fractures we see often because that's a common injury for so many reasons, from simple running and tripping or sliding into a base or jumping off a trampoline or motor vehicle crash, car crash, motorcycle crashes. We see open ankle fractures a lot. They look horrific. I mean, the foot is off to the side, the bones are sticking out, and everybody's freaking out. And you look at it and you're like, okay, I mean, it's an injury. And literally the fix for this is I give the patient some pain meds, try to sedate them a little bit, and I literally like grab the foot and pull it and move it over and it's done. And I mean, they're going to need surgery for it and pins and things, but it looks horrific, but aside from the poor patient's perspective, it's a pretty simple fix. And they're not dying, ever really.
So good to know. If a bone's sticking out, don't panic because it's probably
No.
probably
I mean,
not
really,
that bad.
really never panic.
Yeah.
I mean, no matter what's going on,
Yeah.
don't
Deal
ever
with it.
panic. And like, my thing is what's going to kill the person first. You fix that, and then you move to the next thing. What's going to kill them next? Fix that. So just do one thing at a time and keep it simple.
This is a funny question. I'm sure I know the answer, but do you shock asystole?
Are somebody trying to get me? Somebody's trying to get me.
No, I actually put this question in here, and obviously, like a lot of people will say they believe in fine VFib, which
Sure,
is
sure. People like to shock. So it's what we grew up with seeing on TV. Everyone wants to shock the patient who's in cardiac arrest. But no, you don't shock asystole. But do I see people, asystole is never a perfectly flat line. A perfectly flat line happens when you take all the leads off somebody. You get
no artifact.
You get
Yeah.
a ruler straight line. But true asystole is just kind of this kind of short wave. It's not squiggly. That's VFib. But do some people I see them say, I thought it was VFib and it's really asystole? Sure. If you shock asystole, are you going to harm the patient? No, but it's not the treatment for it. The treatment for asystole is good compressions and you only shock VFib and VTAC. Yeah.
What's one medication you think EMS should use more often?
Oh, this could get me in trouble.
Could it?
Oh goodness, yes, because I can see now EMS providers everywhere are going to go to their medical advisor and say we should get this because Dierks said we should. Medication they should use more often. I would have said epi a year ago for like allergies, allergic reactions where you start to get symptoms around the mouth and tongue and stuff, and people would be afraid to go to epi because they associate epi with cardiac arrest. And epi is like the gold standard first medicine you should give if there is any allergy causing potential, more than just a rash or hives. Symptoms above the neck, any tongue symptoms, throat symptoms. I kind of feel like I have a hoarse voice. I kind of having a hard time swallowing, my secretions. Immediately give epi-IM. Other than that, there's not a lot of medications that I say we should give more. I'm big on not giving medications.
Yeah.
Yeah. I think people are overusing
I,
fentanyl.
that's the next question is what's one intervention, and use the word fent so that we don't
Oh, sure,
get
sure,
flagged,
sure.
but what is one
Yeah.
intervention you think gets overused?
And I'm only saying this locally. I don't know if this is more national or international, but places that have a limited availability of what medications you can use to treat pain. I see some places overusing the F-bomb, opioid medication, because it's a great painkiller. It's a great go-to IV painkiller, but a lot of times the patient might not need that level of painkiller. And so you could do, Tylenol or Toradol or something else.
Yeah.
But that's a big gun to jump to unless they're in severe pain. Now, if they're in severe pain, kidney stone, broken bone, absolutely go for it. Um, but again, I should probably give a disclaimer here.
Yeah.
Thank you, Eli. But all this stuff we're talking about is more advisor suggestions. None of this stuff, if you're a patient listening to this or an EMS provider, you can't take what I'm saying and say, Dirk said it, so we're going to do it now. You have to follow your county protocols. Even if you're in Spokane County or Kootenai County or South Carolina, you need to follow your county operating protocols. And what we're doing here is just having a fun conversation.
Yes. And if you guys have any
Questions or comments or anything like that, please put it in the chat. Give us something. I've got some questions I wrote up here, but if you guys have something that's interesting, please put it in the chat. Casey says, "Give us nitrous oxide, doc."
Oh, I approve that for
And
one of my departments.
yeah,
So, yeah, that's a great medication. It's really fallen out of favor because it's such an old medication, much like ketamine used to be an old medication. Then it fell out of favor, and now it's come back heavy. But nitrous oxide is actually probably the go-to medication for BLS level providers, AEMTs, who maybe are in rural settings who can't do IVs, can't do IV pain meds, can't do IV sedation, but you have a severe painful injury, peds or adults, and nitrous is
lack of
extremely
contraindications,
safe.
right?
Yeah.
And the half-life is
They
you
give it
take
in
it
dental
away.
offices,
Yeah,
right? The thing is, it's so nice because you put the little nose mask on them, and the patient does the medication themselves. They hold it on there, and if they get too sleepy, their hand falls away and the medication falls off, and they wake up pretty quickly.
Yeah.
That's why it's such a safe medication for the BLS stuff. What's interesting to me, and I've thought about this for a while, is why is there such a difficulty getting nitrous back into the hands of BLS providers? And I don't know if there's bureaucratic political stuff behind it, but it's like, was it because they don't want to give BLS providers that much more power again
Right. Is it
because
the
maybe
fear
they
of
won't need
misuse?
ALS as much?
Yeah.
I don't know. Or is it like, you have medical advisors who are nervous to allow their BLS providers to use nitrous, or maybe they don't want to train on it.
yeah.
So I don't know. But I think it's perfectly appropriate for like a BLS department in a rural setting to have that on their armor.
I have a couple hot take questions. Do you know what hot takes are?
No, it sounds exciting.
So it's really just your opinion on certain things. So, like, for instance, this says, should EMS crews be allowed to refuse obviously non-emergency calls?
Great question. So this is something that separates really urban centers from less urban, kind of medium-sized towns and more rural. So in the smaller towns and medium-sized towns, you typically have enough resources, strained, enough resources, they can meet the 911 call demand. And in general, if somebody calls 911, the safe bet is pick them up and take them no matter what they say, because their toe injury may actually be an emergency. Maybe it is osteomyelitis, an infection in the bone, and they have diabetes, and they actually have brewing sepsis in their foot, and that's their toe pain. The trouble is when you get into the urban centers where you have, millions of people, homeless everywhere, constant 911 calls, and you have to have some sort of pressure release valve so the system doesn't completely crumble. And so only in those really urban centers, downtown EMS response areas, fire department response areas, where they get so many calls that if they truly took every patient to the hospital or called an ambulance for every patient, the system would crumble. It couldn't survive a day. And so those places do have protocols in place where their MPDs or their medical advisors in charge will give them the power that on scene they do a history and a physical, and the paramedic or the responding unit can make a judgment call of non-transport, and they'll turn the patient away and say, you can call a cab or get a ride, but we're not taking you.
Is that something you'd like to see here in Spokane County?
I don't think we're there yet. I don't think we have that population, and we have plenty of transport providers, and we have plenty of EMS. I mean, the system is strained, but I'm actually seeing more of the strain is at the facility level.
Right.
Is
People
where,
just walk in with their, yeah.
yeah, and I mean, I'm seeing at the facility level, EMS will show up, but there's no place for that patient.
Sure.
And so the EMS is keeping up with demand from my assessment. But where we're not keeping up with demand is the hospital. And again, that kind of comes down to like the overuse of the system to begin with. Because there's so many EMS patients I see that I'm like, why did you call 911? Like, what? You called an ambulance for this? So that's where I think the problem is.
Do you think building a new hospital here would solve a problem if someone were to come in and build a new center?
No.
No.
No, we have, I mean, for the town size we have here, we have a lot of facilities. The trouble, I don't think, is so much the facilities, it's just the people accessing the system. And I mean, one of the problems I mentioned earlier was the amount of clinics and outpatient resources and urgent cares who just dump people in the ER. I mean, case in point, I mean, this is every shift we see this, but I had a patient recently who was a cancer patient being treated as an outpatient. They went in for a regular lab draw, and they got their labs drawn that day, and somebody who was on call who doesn't know them got a lab alert saying one of your clinic's patients got a lab draw today, and the red alert was their hemoglobin. They were anemic. They had low blood count. And the blood level was at a certain level where, like, yes, it's low. Would I transfuse at that level? Maybe if they're super symptomatic. And so the person got a call from the on-call provider who had never seen them before, and they just said, you have this red level that's bad. You need to go to the ER and get a transfusion. So the patient comes in, drives appropriately, doesn't call 911, thankfully. I mean, that was appropriate. They come in, they wait several hours to be seen. I walk in and finally see them, and I see this normal colored human being, no pallor or cyanosis. He's not pale. Everything is normal. I even ask him, like, well, how are you feeling? He's like, I feel like $1,000,000. I feel great. Better than I have in a long time. And I brought up the labs, and that level, when you track it out over the last month, was about the same, almost a little better. So he'd actually been slowly getting better, but he was still in the negative range, in the bad range, but getting better in the bad range. So he was feeling great.
It's a long-term problem as opposed
So
to
this
an
is a
immediate
chronic issue.
Yeah.
And this person was sent to the ER, sat in the ER waiting room, exposed to other illnesses, right? Could end up with a viral cold or pneumonia, could kill him.
Right.
All because they had a lab draw that turned red, and the on-call provider or the tech or whoever called them with that result didn't take the time to just like look.
At their trends.
And
Yeah.
so that's where the system's failing. It's not EMS. It's a greater issue of like everybody's burned out, staffing's low, and we need to think critically about who you're going to truly send to the ER or not. And like, does this require an ER visit right now?
On that topic, with the increase in popularity of people having their medical records on their cell phones, and they go get a blood draw, and within hours you've got results, do you see patients coming in who have just seen a doctor for something, and they come in and they're like, my white blood cell count is like elevated 4
All
points.
All the time. So it even gets worse. So not only can you see it on your phone, and every human being, me and you right now, we're feeling great. We're normal. We're not sick. If you drew our labs right now, or got a CT scan of our chest to pelvis, there would be abnormalities.
Yeah.
That's normal. Everybody's got little abnormalities. You might see a little nodule here or a cyst here. Your lab work is going to be abnormal every day. There's little things that vary throughout the day, right? If I went outside right now and ran around the building really fast, or you scared me and like attacked me, my white blood cell count would go up. Like, that's normal. My neutrophils would go up. That's normal. And so seeing your labs and imaging accessible on your phone is a blessing and an absolute curse. And to take it one step further, talking about that little old patient who's been waiting for 9 hours to be seen, if they've already had lab work and imaging done, maybe out of triage or nursing orders, they have those results. And so you'll walk in and they're like, I've already seen them. They're back before you are. And they're mad at you because the results got back before you got there. Or worse, you saw the patient earlier, you put in the labs and imaging, you go and see more patients, the trauma, the cardiac resuscitation, the dying patient, the sepsis patient. Their labs and imaging came back an hour ago. The results were back an hour ago. They got it on their phone, and now you walk in to give them an update, to talk with them about the plan, admission, or discharge, and they are pissed because they've been waiting an hour with their results, and you've been out just screwing around.
On your
So
phone.
yeah. So
Scroll on the internet.
it's a total curse. I wish people didn't have access to it. It's nice for the whole, portability of it, going and having it accessible, but boy, does it come with some complications.
Yeah.
And so a question on that, you said that sometimes the physicians will get an alert about a patient's blood work or whatever. So if something is truly wrong with you, you go to the doctor, 3 hours later, you start getting test results back and a bunch of stuff looks bad. Does your doctor see that right away? Is this something they review?
If they look, they'll get flags.
Yeah.
But again, we see red stuff all the time, and so
Yeah.
generally they should review it and then evaluate, is this an emergency now or is it okay to wait? And most of the time, if your provider is actually reviewing it, the person who ordered it is reviewing it, they won't, over exaggerate or overcall something. It's when the after hours person reviews it, the assistant in their office reviews it, the lab tech reviews it. All they see is a red number and they freak out. And you go, that doesn't help.
Okay.
Let's stay calm.
Casey has a question. He says, hot take. What is your opinion on the use of DILT in the pre-hospital setting?
Diltiazem. So I'm old school in that I like DILT. DILT was my go-to for AFib. So diltiazem is a medication that slows the heart rate. It's a great medication that slows the heart rate, but there's a lot of data and literature behind it saying it also has detrimental effects. It can tank the blood pressure. And so some people, even in the cardiology world, don't like DILT at all. And I definitely don't blame them for it. For over 20 years, I used DILT go-to many times for atrial fibrillation with rapid ventricular response. It's that irregular heartbeat that's really fast, and it makes the patient feel lightheaded, makes them want to pass out, low blood pressure. And so I would give DILT because it was a great test. You'd give this diltiazem bolus, and it's so fast you can just see the heart rate slow down in front of you, and you can actually see the underlying bad rhythm and figure out, is this truly AFib or is it something else I need to treat? I had never had a bad effect from DILT. And maybe it's more of the people get put on a DILT drip, that kind of thing is bad. But it has definitely a negative connotation in current medicine. It's really avoided. But just anecdotally, again, I used it for 20 years and I had great effect and it worked great for AFib. Granted, long term, it's probably not good.
No, I had no idea what DILT was. I thought that was a naughty acronym.
Yeah. And so now in the EMS world, we used to use it a lot, and now it's being taken off a lot of protocols, which is fine because there's other medications
Yeah,
to use.
I have new medications every day, right? What's the funniest interaction you've ever had with an EMS crew? Can you think of anything?
Funny with the EMS crew, I guess on or off shift, because we do training off shift,
Right.
which can
Well,
be
let's
really
do
entertaining.
on and off shift, and if you can't think of something on shift,
So
then
on shift is hard for me because generally when I'm working in the ER, it's pretty serious. I don't laugh and joke a lot because I think an ER is a pretty serious place, and if patients hear laughing or giggling, it really bothers them, and I think that's appropriate. So I'm pretty cold and businesslike when I'm on shift in the ER. More of it's probably, if it's on shift, it's outside the room. But it's always dark humor. What we work in, you got to have dark humor to be able to survive it. Like in the movie Code 3, it's one of the reasons I love Code 3 is because the dark humor in that is great. But the last time I saw in the ER, and this is going to sound pretty dark, but it was a case, this was years ago, of a motorcyclist who crashed out going a little too fast on a little too much meth and
A little too much.
clipped their body parts on a rail along the side of the road. And in clipping their body parts, lost an arm and a leg, sheared them off. And so came in as, a bad trauma and, sick and resuscitated and did fine. But EMS brought in the arm and the leg appropriately to just in case they could be reattached or whatever. And so when I walked out of the trauma room resuscitating the patient, there was a garbage can with an arm hanging out and a leg hanging out. And I just stopped and I looked at the EMS crew. I'm like, if there ever was a time to do a PSA commercial about motorcycles and meth use, isn't this it? And we kind of had a cute chuckle about it. And that's the dark humor of emergency medicine, right? Off shift, it's like the training when you do like emergency delivery or something like that, and you get this like either a young male or old school grandpa who's practicing doing emergency delivery, and it's just stuff like that that's kind of entertaining.
I'm seeing a sticker design possibility here with a
Possibly.
ER garbage can with an arm and a leg hanging out of it.
Pretty
Yeah.
good.
Yeah.
A PSA.
Yeah.
And this is coming from somebody like, I would love a motorcycle. I would love to go fast on a crotch rocket. I'd love to have a super fast motorcycle, but I will never have a motorcycle because I've seen the consequences.
Oh, sure.
And it's virtually never the motorcyclist's fault. It's, the car that didn't see them or whatever. But yeah, I can tell you, if you do drugs or alcohol and then you get on a motorcycle, I ain't gonna
It's
go
gonna be a
well.
bad
That's
day.
gonna be bad.
Is there anything else you would never purchase after we're living in the Eli
I
with
like
the
that.
continuing education?
Yeah, that's true. Good job, Eli.
Shouldn't cost you an arm and a leg.
Yeah.
That's great.
That's
That's very good.
nobody can
Write
coin that. That's
down.
ours.
That's ours.
EMSConnect.
Yeah,
Ricky Bobby.
trademark. Ricky Bobby. Is there anything else you wouldn't purchase other than a motorcycle after the things you've seen? Anything that comes to mind of like I would or something I wouldn't do?
A pack of cigarettes,
Okay. Yeah.
meth, heroin, the F-bomb. I would not purchase those. Marijuana in general, I wouldn't recommend it. I wouldn't recommend it. Not unless you have like cancer-related pain or something. But other things I wouldn't recommend.
Side by sides.
No, that's totally fine. Totally fine. But I would buckle up.
Yeah.
I think if you mix any substance with ATVs, UTVs, four-wheelers, three-wheelers, you're asking to die. I mean, that's just the reality of it. Squirrel suits, parachuting. The parachuting is pretty safe.
Yeah.
Those squirrel suit people who
Oh yeah. They like
fly,
yeah.
every one
gliding
of them
suits.
dies.
Yeah.
Like you should like look up the statistics of how many of those people actually like are able to grow old. 0. They all die.
The pros all die.
Oh, they
the
all
under
die.
40. Yeah.
Yeah.
That's crazy.
So don't buy a squirrel suit.
No squirrel suits.
No.
Okay, we'll write that one down. What's one medical myth you want to eliminate forever? Medical myth.
That EMS and ER physicians can fix everything you have.
That we're gonna be able to
that
save you.
that
for
I think
sure.
that is the myth. Like people come to the ER, call 911 thinking like, oh, they're gonna diagnose it. So I get it all the time. What brings you in today? Oh, I've had this thing going on, like, and it's really bothering me. And it's like 2 a.m. And you're like, so when did this originally start? Like 9 months ago. And my doctor can't figure it out. I've been to 5 ERs, the urgent care provider, chiropractics, and nobody can figure it out. And I'm tired of it. And you kind of pause and look at the patient at 2 a.m. What do you think I'm gonna do? Like, what? What in the hell am I supposed to
Been
do that?
knowing you for 9 months, but I'm gonna be able to figure it out for
Like,
sure.
really? Really? Like, and you're in an emergency department, so you can't just like get a willy-nilly MRI. Just gonna get a CAT scan. Let's just draw some blood work while we have the dead people waiting, people dying. And so you try to find this nice way of telling the patient, you try to sit down, let's talk about the timeline. So 9 months, nobody's figured it out, and I'm just meeting you. I don't know you at all. I barely have done a history and a physical on you. Like, do you think I'm gonna diagnose this tonight and like fix it? And like you try to get to a reality base, like
to a realistic
what
expectation.
planet are you on, right? So that's a myth that I think is just rampant, is that modern medicine and the ER shows and the cool medical shows have really given people their perspective that like if you go to the hospital, they're gonna figure you out and fix you right now. And while that's true for some things, it's not true for a lot of others.
I have left the ER feeling dumb before. Have you? I don't know. You
It's funny, I
obviously
leave
as
the
a
ER feeling dumb
doctor,
every day.
but like, have you ever been? You're like something's, and you're like, this isn't good. This is like I need to go right now, or with a
Well-
kid, or with your child. And I know as a parent, we tend to
with
do
your
that
child,
where
everybody's
it's
an
your
idiot.
kid is sick, and you're like, I don't know, their effort to breathe just seems really bad, and
Yeah.
like you're checking their SpO2 at home, and it's like 92, and you're like,
No, I'm sure you're the same way as I am. Like knowing what we know and how bad things can get from just the minor issue, like a scratch can turn into necrotizing fasciitis and you're dead in a few days. So knowing the things we know, we make terrible patients, even worse when it's our kids. If it's my kid and there's something going on, I'm like, is it cancer? Is it cancer, right? Like,
It's cancer for sure.
it's cancer. And you're going to be dead in a year. Like, you freak out
Yeah.
because you see everybody else dying and everybody else is suffering from stuff. And you're just waiting for
your
that moment, right?
Yeah.
And you know it's coming, right? We're very in tune with the fact that everybody
Nobody
dies of
gets out
something.
alive.
Yeah. So yeah, we make terrible patients. We always assume the worst, and that's everybody. I mean, I am the same way. I'll have some new ache, and I'm like, oh, it's cancer. Yep, I got cancer.
Bone cancer.
Yeah.
It's money.
Yeah. But when I'm dealing with other human beings, I'm reassuring and common sense and practical and calming. And I'm like, oh, the odds are perfectly fine. You're fine. But then, I'll get like, hiccup. It's a heart attack. Yeah, we all do that a little bit.
Yeah, that random chest pain that you're like, is that a pulled
That's
muscle?
my PE.
Yeah.
I'm dying.
Yep.
Yeah.
This is it.
Yeah.
Night shift forever or day shift forever?
So this is going to be very personal opinion. So we'll do a disclaimer again. None of the things I say should be taken for medical advice or change your protocols or take for your own personal, whatever. So night shifts for me have been horrible. I think the natural human ability is when you're young, you're very tolerant, flexible, your body can recover quickly from all sorts of traumatic things, whether that's physical or mental. When I was early in my career, night shifts were still exciting. Crazy stuff happened and the crazy people come in and the drug use is, oh, it's nuts, right? It's a classic chaotic ER. And when you're young, you kind of feed off that chaos and it's still exciting. You're like on TV, you know? And as you get older, the night shifts are just horrible, like horrible. And you still feel like a zombie for 3 days after the night shift and trying to recover. And do you have to take a sleep aid or not? And now are you taking a sleep aid? And how healthy is that to regulate your sleep? And so I think I think the data is well showing that night shifts are not good for anybody.
Right.
And there's like that tiny less than 1% of the population who are just great night owls. And that's just how they function. And these like charge nurses who've been doing this for years who have like, that's their night shift. And that's like how they function. Great. Awesome. But for me, night shifts have been one of the primary factors of like me wanting to get out of the ER as soon as possible. The day shifts, the sickness, the people dying doesn't bother me. It's the nights, they just kill me. And I think it's because, as a parent as well, the day before your night shift, how do you regulate the sleep? Are you going to miss your kids' activity at school? Because, to be safe, to be on that night and fully mentally with it, you should sleep this part of the day. And you kind of figure out this is when I would feel the best, I'd sleep the best, wake up and go do my shift. But what if you have kid care issues? What if you have kid activities? What if you don't want to miss your kids' stuff? What if your spouse is also working and you're the responsible person for your kids and have to pick them up from school? And so the day before your night shift, dangerous. And then your night shift destroys you mentally. And you come home the next day, and I don't know how other people are, but I'm destroyed after night shift. I am a zombie. And then you come home the next day, and what does that day look like? Yeah. Do you work again that night? Right. Well, then that day is screwed. Or if you don't work, that recovery that day it's not just like, oh, I'm going to flip back. It's not like that at all. And the older you get, it takes me 2-3 days and I'm still feeling that night shift.
And obviously, we will never be able to get away from night shifts
No.
because the public has emergencies from
Yep.
midnight to 6
Yep.
a.m. Do you think that there's a solution somewhere for how to keep providers from, suffering the consequences
Yeah.
of night shift regularly?
Yep.
Is it a schedule thing? Do we schedule them, once a week it's your night shift or once how do you?
So I'm a self-proclaimed capitalist, okay? So
Yeah.
I think that this is all the system should function how it would be most sustainable. And I think night shifts are, we do have to do them. And so if you're in a partnership or employed and everybody shares nights, that's great. Then it's shared equally and everybody just has to suck it up. But I also think there should be the incentivized, if you do have young new providers coming in who have the energy, who can rebound quickly, you also incentivize by saying anybody who wants to pick up nights, we pay nights better. And you make it so that it is a big benefit. If you want to work nights and suffer that, you get paid better. You get treated better, better benefits, whatever. But something's better. And you're not just forced to do it because you're young. No, I think that's kind of a crappy move because what it does, it creates bitter, angry, burned out people who then, as they get older, they're just pissed and they hate the people that made them do that. It's not like you're buying into a partnership. It's not like you're buying shares of a company. You're suffering. And so if you're going to have people suffer or have them take on that burden willingly, you got to incentivize it significantly.
Absolutely, I agree. And how does that transfer to EMS? Because obviously, or even the fire department, when you're working 24-hour shifts, there's no way around it. You're running calls at night.
No, I think with the fire department, again, I'm not a firefighter, so I can't speak for them, but my impression of like the fire shifts that you're on for 24 and off for a couple days, that's just luck of the draw. Like some nights are going to be great and you sleep, some nights you get hammered all night. And that just sucks. That's part of the career. But I think outside of that, in shift work, 8 to 12 hours, that I think is you incentivize it. So if you're an EMS agency and you need providers on nights, you make it so the nights are almost people want to fight over them. You make
Yeah.
it so incentivized that you almost have a problem. People really want the nights. Same
Yeah.
with the holidays. You
Pay 'em
incentivize the
triple.
heck out of it. Yeah. And knowing that, like, you just make that move business wise of you tell your day providers, hey, if you want to work more days, that's fine, but you're going to get paid less because we're going to pay our night providers a lot because if you have that problem.
Yeah.
Now, if you have a situation where everybody's fine working it, fine. That's you don't have to pay them differently, but you definitely need to incentivize things.
Absolutely. So I have some questions about our conference. Obviously, that is coming
Oh, how
up, so that'd be
exciting.
fun to talk about that. Do you want to do a quick rundown or just a quick like conference info
Yeah,
thing
sure.
for anyone who's new joining
Yeah,
us
this is
today
super
who doesn't
exciting.
know
Yeah.
who we are, what we do, what we are going to be doing?
Yeah, so we'll put it on the screen now, but this really smart guy named Sean Pitts, several years ago, kept telling me, this company needs to have a conference at some point. Really wanted to have a conference, put on our own EMS conference because we go to all these conferences around the country. We promote our system. We have great educators now. We do great content every month. We have a good reputation going of being solid educators. And we've made acquaintances all over the country with solid presenters and instructors. A lot of them have already been on EMSConnect. And so we finally looked at the logistics of it and said, yeah, let's do it. So next May, the last weekend of EMS week, I think May 22nd, 23rd, it's a Saturday, Sunday, and we'll probably have some activities that Friday evening as well before. We're going to host a conference in Spokane at the Grand Hotel right downtown. Great setting, best time of year to be in Spokane. Early spring, it should be lovely. Everything in bloom. We actually have Bloomsday here in Spokane where, lilacs bloom. It's that
First
time of
Sunday
year.
May.
Yep. And so we're going to have a conference. It's going to be 12 plus hours, day and a half to 2 days. Lots of presenters from around the country. So it's not just local. This is going to be a national level conference. We're going to bring in guest presenters from all over the country. Our keynote speaker is, I'm going to hold that for now. He's a national author who knows EMS very well. Solid presenter, solid educator, super down to earth guy. We're going to have lots of cool educators, breakout sessions, skill stuff. Should be a lot of fun.
Yeah, and anyone who wants more info on the conference, our link tree and all of our socials will get you that information. You can also go to our website,
Yeah.
EMSconnect.org, and find that information as well. So what's something fun happening outside of the lectures?
Yeah, so a
If
lot
you
of
wanna hint
conferences
or
I've
give it
oh,
away.
absolutely. I won't give it away. So as an ER physician, I've gone to conferences where, you go, you sit there for hours, you get your education, blah, blah, blah. You go back to your hotel room and you sit there by yourself, or you go out to eat by yourself. You're lucky if you're with somebody who's actually going to the conference as well. And I just don't think that's cool. I think a conference should be kind of a grand event, like fun.
Yeah, like you're
Whether
paying
you're
To be here. Let's have
Yeah,
a good time.
absolutely. And you're in a great place with, let's face it, this company is made by a lot of fun people. And so let's have a good time. So the night before the conference, we're probably going to be doing something really fun. The night of the conference, Saturday night, we're going to host a social event where do it if you want to. It's free to participate. If you're if you're an attendee of the event, you're automatically in if you want to be. You don't have to be. Do it as a solo or as a team. It's going to be fun in downtown Spokane.
yes,
Uh,
some hopping.
some huge prizes, and like huge, I mean like holy shit, like never in a million years I think at a conference you could potentially win this stuff. But yeah, it should be a lot of fun. We're having some good sponsors. The social event should be a ton of fun. You're going to be hanging out with us,
Us.
EMSConnect. We'll be running the conference. We'll be there answering your questions, hang out with us, party with us.
Accessible,
Yeah, it's going to be a good time.
If someone could only attend one session, and I'm going to reword this to like one breakout, which should it be? And we don't have a full list yet. And if you are an EMS educator and you are looking to grow your portfolio, we do have the speaker submissions still open, I believe.
Oh yeah.
And that's in our link tree as well. But if you could go to just one, thinking of, you don't have to give away who it is speaking, but
Well,
it's like a topic or something like
I
that.
haven't gotten confirmation if he's willing to do breakout, but Professor Sean Pitts from EMS Connect, I want him to do a breakout and I don't even know what that breakout would be, but whatever it is, I would want to see it because you talk about a solid educator. It's why we hired him. So I would go see Sean in person, live at EMSCon to do a live session. That'd be pretty cool, pretty fun. Solid
And
educator.
you've heard him. Have you heard him like educate?
Yeah.
Because obviously his job, he's doing a lot of hosting and stuff of the other educators. And have you got to sit back and watch him in a big class?
So back years ago,
Yeah.
we both educated as part of a paramedic program.
Right.
And so, yes, I've seen him educate, which is why I stole him from his previous employer to work
You
here.
did. Well worth the steal. Which let's see, let's skip that one. Who should come to this conference?
Oh, so it's for all levels. So part of the company mission is I am really against how EMS education online, like high quality stuff, is just for paramedics, right? Because paramedics are the only EMS provider out there, the only person who can do really important stuff. I think that's crap. I see BLS providers who can run codes better than some paramedics because it's all about good compressions and early defib. And so this whole conference is meant to be for the first responder to critical care. And we are going to have sessions for everybody. We'll have breakout sessions for different levels. So absolutely, if you're BLS, this is anywhere in the Inland Northwest, multiple states or even national, this is for you. This is perfect. Yeah.
I think that we're going to set the bar so high, people are going to be like, why am I going to these other conferences when I can go to Spokane and I can have the time of my life and I can win prizes and get good education, great education.
The good and the bad about that is I hope that's true.
I
but,
hope
But if it is, it means Sean Pitts was right for years. And
You're going to have to eat that crow.
Yeah.
Possibly.
Yep.
What's one skill attendees will leave with?
I think it's going to be better patient care at the bedside on scene, more than just like, oh, I'm doing the right intervention. Our keynote speaker is big on
Legality.
just doing your duty.
Yeah.
Like EMS providers, I think, have lost significantly what their role on scene is. They think like, oh, if they don't need an IV or meds, like it's not worth it. Whereas that's like the way at the end of what you're there for. You're there to establish a patient relationship, to provide what care is most necessary. If it's that little old person who's cold and calls 911 from their house 60 miles outside of town, and you get there and they needed a lift assist and a warm blanket because they're cold, but they don't want to go in, some EMS providers would get really angry about that, when in actuality, that was your duty to provide a customer service for this person to begin with. It might not need medical care. It might not need trauma care. What they maybe needed was just some assistance with things. And so I think that's going to be a big thing, is walking away rejuvenated of why you got into this in the first place, and kind of refreshed of like, it's not always about the resuscitation, the needles, the compressions, the shocks, the dual sequential defibrillation, all this cool stuff we do. Maybe it's just about being a good care provider.
I think the spark for, to be good customer service provider.
Yeah.
Which is really ultimately the core of what we do is customer service.
Bingo.
So.
And that's what people forget, and that's why we're burning out.
Yeah. And it's funny, Eli put this question up here. I don't know if this came from one of our platforms or not, but he said, what makes EMSConnect as a platform different / worth it for providers, which is funny because I have what makes our conference different compared to others.
Sure.
So if you want to touch on how we are different.
So the recipe behind what the company, how it was created is really unique. And I think what separates us from the competitors out there online for like the LMS platforms is that the recipe was, we brought emergency physicians, EMS physicians, paramedics, the cream of the crop trainers, the BLS providers. We cherry picked those unique individuals, not just for their educational content, because there's a lot of smart people out there, but we brought them on board because they're engaging, they're human beings, they're fun to talk to, they make the education not just this drudgery, okay? It's about having a good time while also getting the content, because then you remember it longer. So we created this recipe of, we only bring on people who we think are going to be super engaging and satisfying to the customer, but then we knocked it out of the park by making the cost so low that inevitably when we promote this, like if I've gone to conferences before as a vendor for EMSConnect, or I've been trying to sell this to an agency who's thinking about switching from what they're using to use us, the question I consistently get is like, okay, what's the catch? And it's so fun consistently to show them there is no catch. Like, there's no bullshit. I'm a working ER doc. I'm a dad. I'm doing this. You know, Sean Pitts is a working firefighter and he's doing this education. We're all busy doing stuff. And so we don't have time for BS. And so the point is, you know, it's a flat rate. It's this much a month. It sounds low, but like the point is we have so many people online now that like it is profitable. And we get enough people online and the family keeps growing that we can provide great content. We do it from our great studio. You watch it or don't, we don't care. You know, take it or leave it. And there's no
I
BS.
think the catch is that we just want you to be better.
Yeah.
We want you to get less done.
Enjoy it.
Yeah.
And enjoy it while you do it,
Yeah.
because I have to do the same thing. I have to take mandated education every few years, and it pisses me off how boring it is. Like, make it at least a little engaging. I have to pay for it. It's not like it's free. I'm paying for a service.
Right.
I expect a little bit of enjoyment out of that.
We have a comment here from, I think I know who this is, but they said, I heard your multimedia guy does great EMS stand-up comedy. Maybe he could have a breakout session.
No.
He says no.
Yeah, we'll pimp Eli out as fast as we can.
Yeah. We so appreciate him. And you kind of stole him from the YouTube world, right?
I don't know if we can ever talk about Eli without his permission, but Eli is an extremely talented young man who, yes, has been very
He's
successful
upped
on
our
YouTube.
production value leaps and
Oh,
bounds.
man,
Look at this place.
Eli. Whew.
Thank you.
He's over there blushing even more than he naturally does. What's one topic in EMS that deserves more discussion? And I think this could kind of be a little Easter egg for something we will be talking about greatly at the conference.
It's hard. I mean, the burnout's there. We all know it's there. But we're talking about that a lot.
I think that gets quite a bit of attention. the
Yeah, it
burnout. I mean,
does.
even the public knows.
I'm
I
trying to
at this
think
point.
about something in the first responder EMS world that isn't talked about a lot that should be. I mean,
I think. Oh, we have not mentioned that. In fact, I don't know how I skipped over that. I think the question I was going to ask was, what's an EMS hill you're willing to die on? And I think that fits pretty well with your prop back there.
yeah, I mean, the backboard. I don't know how many sessions and podcasts we've done where Sean gets me riled up about the backboards, but yeah, for anybody who wants to know my opinion of backboards, go check out EMSConnect for only $7.50 a month. We have free podcasts as well. Yeah, I think trying to think of something that should be talked about more.
Legality. I mean,
Yeah,
what you're doing and
yeah, I
how you
mean,
do it and covering your ass.
there's a lot of EMS providers and frankly ER providers, but I think it's more present in EMS who want to be the hero, like they have that hero mentality. Whereas I think most ER physicians are so burned out, when we leave the ER, we're just like, we're turned off, we don't care. But in the EMS world, I think there's a lot of people who have, you know, a go bag, and you know, in the back of the car, in the truck, they have equipment and supplies in case they're driving on vacation and they come across the rollover and they're going to intubate off shift. They're going to needle decompress off shift. They're going to do some crazy stuff. Going to crike, going to cut a neck off shift.
I just want you to know I'm doing that to my family if I need to. You heard
Straw.
it here first.
Put a straw.
I'm doing it. I don't have the training, but it's,
And so I
it's going
think a topic that needs to be addressed more often is just how we behave both on and off shift. On shift, I'm seeing medics that, you know, kind of have the God mentality because they're burned out, you know, sadly. And they think that if somebody calls 911 and they don't need paramedic level care, then like, I don't even need to be here, I'm walking away. And they kind of turn off and forget what their actual duty is. And the duty is to provide care, and that care might just be, you know, supplying some comfort and education, and that's good. That's their job. And care doesn't just mean you do great IV meds and intubate every patient. That's not what you're there for. You know, 90% of the calls, you're not going to be doing that. You need to be a good provider. But off shift, I think, is where we have some troublesome areas of how we behave. And I think depending on where your location is and what your licensure is and what your state laws are, you know, there's bystander Good Samaritan laws, but that doesn't mean that you're a Good Samaritan if you have a go bag off shift and you pull up and intubate somebody or cut their neck. That's not good.
Because you are no longer covered by.
And Good
insurance by
Samaritan
your
laws
agency,
don't
right.
cover somebody cutting somebody's neck
Right.
or intubating
Yeah.
because a Good Samaritan isn't held to that standard. A Good Samaritan law is held to the standard of any bystander who walks by. What would that person logically do, expected in society? To a normal training, a normal layperson's training. So yeah, do rescue compressions. Do the stuff you think is appropriately. Direct pressure on a wound. That's okay.
Yeah.
But if you start cutting necks or chests or needle decompressing things or intubating, you got a big problem.
Yeah.
Because if that goes great, maybe you'll be held as a local hero, you'll pat your back, and sadly will reinforce your bad behavior. But if it goes badly, your career's over.
Well, and you talking about losing your home and your,
Everything.
I mean, everything.
Everything. Nobody can defend you.
Yeah.
Because you're not even on your company's insurance at that point.
Yeah. And I think that what's his name? Dang it.
The
legality guy.
David Gavatt.
David has mentioned that before about how you are putting everything on the line. You think you may be being a hero off shift, but really you are putting your family at risk, your life at risk.
Yeah, if you want to read a good book, go check out Sirens, Lights, and Lawyers by David Gavatt. It's one of those books that now, if I talk to a med student or a new EMT, I demand they go read it, even as a med student, because there is lessons for everybody in healthcare, because it's all about duty and patient care and what your expectations are both on and off shift. And so we have them on the screen now if you can see that. But David is a solid educator. He's super down to earth. He's fun to listen to because he's so down to earth. Yeah, he's
just
funny.
a normal guy.
Yeah, and his book is a fast read and it just makes sense and it's an easy read, but it's one of those reads where you're kind of like, even I was doing it. I was reading, I was like, oh shit.
Oh,
that's
that's me. Yeah.
Yeah.
It's
like,
convicting.
it's
It's
bad.
an EMS Bible, if you will.
Oh,
you read it, you're
yeah.
probably going to feel convicted
It's
and
like
you might need to change
the best,
some things.
worst book I ever read because like you're reading, you're like, oh, this is fascinating. Oh crap, that's me.
Yeah.
Yeah.
Yeah. Oh, no, that's me. Yeah. Oh, that's too funny. You have some friends in the chat. Maisie says, hello, Dr. D. Hope you're doing well. And then Lavishing Rose says, thoughts on continuous high quality CPR versus 30 to 2 during single rescuer CPR.
Oh, single rescuer's misery. So no human being can do continuous compressions beyond 2 minutes, despite how buff and huge and physically perfect they are. It's been pretty well shown that at 2 minutes, your efficiency, your quality of compressions is going to start declining quickly. I recently was doing a training with one of my departments, and we pulled out the simulation mannequin where it shows you your percent of quality CPR. And we hid it from them and said, okay, 2 minutes, go. And we had different people do it. Some people do good CPR for a long time. Some people just physically can't. Knee issues, back issues, body habitus. Like a 90-pound person can't push on a large barrel-chested obese person enough to compress the heart. It's just not possible physically. And so I don't think every human being in EMS should be the compressor. I think it's no different than any hockey team or baseball team. You have positions, and this person is good at compressions. This person's good at running the monitor. This person's a great bagger and gets a good mouth seal on the mask. And so I do not think that every EMS provider should be on the chest during an arrest, but I also don't think that anybody should do it beyond 2 minutes. You have to trade off. And if you're a single rescuer, you got to take a break. I mean, there's no way. At 2 minutes, you're not doing anything effectively anyway, so what's the point? But yeah, you want to get help. But with that, if I was a single rescuer or even with a crew, and there's only so many staff, I will pull bystanders in. Absolutely. I'll pick them out of the crowd, and I'm like looking for the ex-Marine, the big dude who's going to have some mass, who can really push on a chest. Say, you come here. I'm going to show you how to do this, and I'm going to teach them how while I hold the pulse, and I can then guide them. Okay, you're doing great. Perfect amount, perfect depth. While I take a breather, and then I'm going to trade with them. Absolutely. Train people. Yeah.
That's really all the questions I have for you. Is there anything that you want to touch on?
No, I would say,
today?
check out, if you're not a customer already, go check out the site. It's beautiful.
We got a
And
free month in the link tree too.
absolutely.
Try it for free.
And again, it's, as an individual, it's $7.50. It's unlimited access, day or night, from anywhere in the world on your device. Go take as much or as little CE as you want for $7.50. If you don't like it, you can cancel the next month. You spent $7.50. That's it. The cost of, like, it's way less than a movie these days. Way less. I mean, that's like a coffee at Starbucks, right?
Yeah.
And so go check it out. Prove me wrong. Go take the content. Send us an email. Tell us what you like or didn't like. But if you like it, it's just $7.50 a month. It auto updates every month. Cancel anytime. Tell your friends. We have agency discounts at $6.50 a month for agencies. And with the agency, it's unlimited access, unlimited people. We give free accounts if you have like a big agency, like a county system, and you just need like a staff member administrator at the top to administer the account. We do all sorts of customized stuff. So just reach out to us and take a look at the pricing page. We have agency calculator on there to see what you're going to charge. But yeah, I challenge you to prove me wrong and to find something better.
And another big perk about the agency side of it is just being able to create your own courses, your own course agencies, and house them within our site and assign them to your users. And
yeah, when it comes to the agency access, it is a full LMS. There are so many amenities, and there's no extra cost for that. So the agency managers will always ask, well, like, okay, I can create my own courses, I can assign courses, I can upload documents, I can manage my roster, I can access your old courses, I can do all this stuff, but like, what's the extra fee? Zero. It's still $6.50 per user, whether you're a manager or not. There's no BS. And so that's what the question we always get is like, what's the catch?
this person says canceled my other $170 subscription for EMSConnect.
Yeah. Yeah. And we see that all the time. And if you want proof, we have testimonials we can send as well. We've taken a lot of customers to the tune of like thousands of customers from major competitors that are out there. And yeah, and that's all word of mouth. That's just us proving us we're not liars.
Yeah. That's why we give you a free month, because you're going to love it.
Yeah.
This is obviously not serious, but should I include alien abductions in my medical history? I want to know that because that's a psych thing.
Yeah. So one thing I do encourage my providers when you're doing your documentation, this is a great follow through. When you're doing your note, your PCR, your documentation, you should include quotes from your patient. And when I say quotes, I don't just mean the crazy stuff of alien abductions. I mean, you're a male provider and the little sweet old lady you picked up makes a comment about how you look, how good you look, or, oh, you're attractive, you're a very well-built young man. Most people just take this as a compliment for what it is and move on. I'm telling you, I would recommend you put that in quotes in your note. It's likely never going to be a thing, right? 1,000 times it's totally normal. It's just a sweet little grandma making a nice, cute comment. But the cases that will come back to haunt you are never the horrible traumas, the people who are dying, the sepsis, the terrible cardiac arrest. Those virtually never come back to catch you off guard. It's going to be that random case where nothing was going on. It was like totally normal. And this little lady's going to come back and say, that young man pulled down his pants in front of me and tried to touch me. And you would never guess it. And you would never suspect it's going to happen. And so I tell my providers, if somebody makes a comment to you that's not just your normal medical history, put it in quotes. And that includes curse words, people swearing at you, people telling you to F off, I'm going to kill you if anything that you're like, that's not normal. People don't usually say that to a stranger. Yeah. Put it in quotes in your history. And that's only because if something bad would happen, it's not going to be next week. It's going to be 5 years from now when you get a letter from an attorney and you're being sued for inappropriate conduct. Well, if you bring up your note and it's just your bread and butter, everyday charted or H&P note, and you provided no further details than like vague stuff, you're not going to remember it. And you have no defense to be like, I don't remember this case. Like, how do I prove myself right? But if you bring up your note and there's little comments of like, oh, she made kind of an inappropriate comment here. Yeah. You can bring that and go,
bring some doubt into
this person was a little weird to begin with. And, my partner remembers that comment. And that's why I document it. Because I just was like, that's not appropriate. Yeah. She called 911 for chest pain. But then when I got there, made a flirtatious comment. So she's obviously not dying and she's flirting with me. That's just weird.
I think that's really good advice for EMS providers. I don't know that I've even heard of that, of documenting things that anything outside of the norm that you put direct quotes in there.
Yeah, and I didn't know that from my training. I picked that up since then in seeing the weird stuff people try to nail people to the wall with. And it's always the most random normal patient. And it's happened to me a couple times where I had a patient turn me into the state years ago and try to get my license removed, wanted me literally crucified in front of medical staff and have to give a lecture on her diagnosis because I had sat with her and talked with her at length about, again, she was a patient who presented with chronic pain for years and years and presented to me expecting me to do certain things and treat her with certain meds that she demanded and wanted me to like fix it. But nobody had diagnosed what was going on for years. And so I'm like, and she's a highly educated, normal human being. And I sat down with her forever of like, I'm looking through your history and all the stuff you've had done. And like, you have low abdominal pelvic pain and nobody's ever evaluated you for endometriosis. And I'm like, I feel like the medical system has done a disservice to you because you've been having this for years and people are like treating you like, oh, it's in your head. And I'm not doing that. And the second I said endometriosis, I didn't realize this. The experience and the interaction went very professional. And I walked away like, oh, I nailed it tonight. I'm a great doctor. I sat down with a patient, thought outside the box, gave a great differential, and I provided good education. I walked away thinking I had smoked it, like, awesome. I'm a great doctor. Months later, I got a letter from the state that she like was basically accusing me of sexism. Because I had said this could be endometriosis, I was saying that her problem is because she's a woman. So she came after me and tried to get me basically crucified and take away my license, my career, tried to ruin me because of some personal BS, right? Had nothing to do with what's going on. And what she did was basically tried to destroy somebody who really was trying to help her.
Now, did she end up having endometriosis?
I mean, no follow-up. I mean, at that point, your life sucks.
Oh, yeah.
Like, it's the equivalent of getting sued, but not really. I mean, really, it's like you're not being sued, but they want to have you get your license taken away by the state. So, I mean, it's almost worse to a degree. So you have to defend yourself and write a letter and support yourself. And I'd have my the chief medical officer for the whole hospital had to write a letter in support of me. It was a disaster. It was misery.
Do you often have other staff accompany you when dealing with specific patients? I mean, female
Yeah.
patients, I know that's pretty commonplace for your male provider and bringing another witness
Yes.
into the room with you.
Never should you do an exam of any part on a human that would be considered private without a chaperone, hopefully of the same gender, in the room with you of the patient. And if you do, you document that always. You know, patient said there was a stab wound to the left breast. You know, I expect an EMS provider to take a look, see if there's bubbling, see if there's sub-Q air, see if it's like pneumothorax. And so it's a simple exam, but like you shouldn't just like, what? There's a breast out. And so you try to have another female present or at least another provider, but you should take a look at that. Now, if it's a different case of like somebody's complaining of vaginal bleeding, and they're normal color, normal pulse, normal heart rate, that kind of stuff, do I expect them to go do a look? No, I don't want them to. If it's, you know, I'm pregnant and I'm having pressure and I feel contractions every 1 minute, do I want EMS to get a look to see if there's crowning? Absolutely, every time, yes. Because if they're crowning, get ready to deliver right now. Yeah. Do not start transporting. Yeah.
Stay and play.
Yeah, stay and play.
Lavishing Rose says, do you think it's bad being a textbook provider? I thrive following the checklists.
I think textbook will keep you safe legally, professionally, but I think there is a human component where you have to be able to talk to other people and within that, think outside the box. Like use common sense. That's a big part of what we teach at EMSConnect is there are protocols for a reason. They're to guide you when you don't know what to do next. But use your brain, use your common sense, and like evaluate that individual patient for what they're presenting with. They're not like every other patient. Every person's heart attack doesn't present the same way. Some are like, you know, nausea only, sweating only. So treat each person uniquely while still working always within your appropriate protocols.
And as far as the checklist comment goes, Sean regularly uses this example, but if you're on a plane and the plane is now crashing, do you want the pilot remembering from what they remember to do an emergency, or do you want them pulling out the checklist? Right? So I think that there's definitely benefits to being a textbook provider, but just remembering to not get pigeonholed and not get, what would you, anchor bias.
Yeah. And people get nervous and they kind of like mind blank, right? You kind of block.
Yeah.
and you don't know what to do next, which is why I always default to if you're panicking, just figure out what's going to kill them first and then attack that and then move on to the next thing. Don't worry about the rest.
Thoughts on scope of practice versus protocols?
Always stay within your scope of practice if you want to have a nice, healthy, long, happy career. Never deviate outside your scope. I mean, I would say never, ever, ever. If there's, if I was at home or at a baseball game and my kid or somebody else's kid goes down and they are dying, would I go outside my scope to save their life? Yeah, but that's my judgment call. If you do that, it's your judgment, it's on you, and you have to know that is the juice worth the squeeze. If you save them, great. Hopefully you're going to be fine and not lose your license. If if you act outside your scope, is it worth the potential consequence? Yeah.
And then versus protocols. I mean, I kind of see it as scope of practice is your career, whereas protocols is your job. And which one?
Yeah, and I mean, if you act outside protocols, I mean, it's outside your scope as well. So I kind of see them as both the same.
That's right.
Yeah,
Yeah.
if you do things outside your local protocols, your state protocols, I mean, you're totally fireable and your career could be over.
Oh, like an example, IM epi is in scope, but protocol for anaphylaxis, but not respiratory distress.
Yes, true. So
Right.
for anaphylaxis, if you can say that my working diagnosis is, bee sting or peanut allergy, and my exam shows swelling of the tongue, breathing fast, respiratory distress, drooling, yeah, give epi. Great, because that's your working diagnosis. But if your, history and exam don't point to that and you give epi, you could be called into question pretty quickly by your advisor.
Okay, well, I think we did
We
got to
nail-
some
we
good
nailed it.
points here. I
We
think this was
totally nailed
good. I think it's good. I think makes for some good clips for our YouTube. If you haven't already followed us on other social medias or this social media for that reasoning, give us a follow. Give us a chance. We regularly do these. I think the next one coming up, we have who's speaking next for our live lecture. We already
I
did
believe
July.
Dr. Micah Dang,
Okay,
and
Micah Dang
he's
in
going to be doing,
August.
I think it's shock. Is that right?
Oh, the Bleeding Edge. Actually, it's July. We haven't done July. Okay, so
Yeah, it's
July
coming up.
29th, the Bleeding Edge, Modern
Reminders.
Shock and Resuscitation Guidelines for EMS.
And Micah Dang, if you don't know him, if you're not a customer of EMSConnect yet. So Micah Dang is one of my local partners here in Spokane. He is an EMS fellowship trained ER physician, and he's like smart. This guy is super smart. And last I know, he was like doing Spartan races. He's a pretty cool guy. Pretty cool guy.
Yeah. So that's July 29th at 2 p.m. Pacific Standard Time.
Yeah.
And so, well, that says 2 p.m. Mountain Time on there. That's not good.
We'll figure that out.
Okay. 2 p.m. Pacific
It's 2
Standard
p.m.
Time.
somewhere.
For you, those East Coasters of you, that'll be the 29th at 5 p.m. Yeah. 3 hours.
Something like that.
Something like that.
Yeah.
Yeah. It's hard. Time zone math can be difficult, especially you start adding in Arizona and Hawaii.
I've lost my
and whatnot.
math skills. As my scalpel skills went up, my math skills went down.
Oh, that's good. I would rather your scalpel skills stay fresh than your math skills.
I leave for the pharmacy dosing to pharmacy
Yeah.
at this point.
Awesome. Well, that was great. I hope
Thanks.
everybody enjoyed it. Give us a follow, give us a like, the things. We will be live again here for sure on the 29th. Maybe between now and then. I'd like to get you and Sean in here just bullshit.
Yeah.
Just go back
We
and
like to
forth.
bullshit.
I know you guys
That's
do.
fun.
Yeah.
That's a good
And
time.
he's quick. He's way quicker than I am with the comebacks.
Oh,
And
he's
you guys
quicker
have a
than me.
good flow.
Oh,
Yeah.
Sean's witty.
He is witty. He's entertaining.
I've lost my wit in night shifts. Night shifts have sucked the wit out of me.
Yeah, we were talking about your blue eyes, and I said they look very blue, and you were like, "Really?" Because I feel like night shifts have drained the color from my eyes.
Yeah, my irises have died
Yeah.
over the years. Yeah.
Yeah, I think that happens to everybody at some point or another in medicine, EMS, the
Burnout
ER.
is almost impossible to avoid.
Yeah,
Yeah.
but yeah. Actually, one last question on that topic. For burnout, what do you suggest? Because Sean gets this a lot when we do lives, right? Is how do you combat burnout or prevent it?
Yeah. Everybody
what's your
has their
answer?
own thing, their own recipe for burnout. Some people, it's, they go for a jog or read a book. It's whatever floats your boat. But the first thing is you have to be able to escape. You have to be able to step away from the job. And if that means shutting off your phone, not checking your email, staying off the computer, don't looking at charts, don't follow up on patients. This is something I push, and it sounds crazy, but I have found much more satisfaction in my job if I show up on shift, to each patient, do the best I can for that patient, and then walk away. I don't ever follow up on people anymore. I used to when I was younger because I was like, oh, this is exciting. I kind of want to learn if I did the right thing. And now I walk away from my shift and I do not come back to follow up on that CAT scan, that lab work. Was there this drug on board? Was there a brain bleed or not? I don't ever, because
It's a trigger for you, and you
like, what if you found out that, like, oh, this person was found to have a huge tumor and now they're dying and they're like 20 years old and they have a little kid? Like, that's sad. That's depressing. I don't need that. Not that I don't feel bad for them. I don't need to take on that empathy. This is where empathy and compassion diverge. Compassion is to help somebody in the suffering they're having at the real time. Empathy is to go through their suffering with them. And so I walk away from that shift proud of what I did, trying my best, and I leave it in the ER. I drive home, and when I get home, I am off.
the next physician's problem.
It's not my problem. I'm done. And I go home and I do what makes me happy. If that's hanging out with the kids, if that's having a glass of whiskey, if that's playing a video game, watching a movie, going outside for a hike, it's whatever makes you happy.
Yeah.
But leave it behind you.
So close the door
Oh.
and keep living.
Absolutely.
Yeah.
And know that you're going to have to go back for another one in the future. So you got to reset before then.
Yeah.
So do what makes you happy in the meantime.
I love that. And then should younger providers follow up still and learn to not do so if it's not for them? Do you recommend that when you start your career, you try,
Yeah.
you look for those, because naturally the
that's a
human
tough one.
spirit, we want to know. We
Mhm.
want that information that we're lacking, especially when we have a hand in what's going on in the first
Correct.
place, right? So we do want, naturally, it's a human
Yeah.
desire.
And as I did when I was in training, I would follow up with a lot because you learn from it. So yes, it's a double-edged sword of, it's good when you're early in your career to try to follow up and see if what you did was right, but that's not so much follow up on the chart. It's maybe have your superior in the fire department review your case. Somebody who's a veteran, who knows what they're doing, who you trust. They're a solid provider. They're really smart and they do good patient care. Maybe take some charts to them and say, hey, here was the case. Here was my question. Here's what I did. Do you think that sounds right, or should I have done this differently? That's probably the better way to go.
As opposed to
Because follow-up of patient care
Yeah.
can be really difficult. So
Right.
for my crews, for example, I can really easily access one hospital system and very hard to access another. So if the patient for them went to the other facility, it's really hard for me to find that info. And you're now asking your medical advisor, go do all this follow-up on all these patients, which legally they can do because it's
within
you as your
HIPAA.
patient.
Yeah.
However, if you have your medical advisor now checking out all these patients, what time is kind of that requiring of the advisor? Is it really worth that kind of time? Is the value you're going to get from it that important? Is the advisor going to have to answer to the hospital system of like, why are you checking all these charts? Because believe me, people monitor that stuff. The worst thing you could do to your advisor is if you are a provider who works at different agencies and you are working at one agency who your advisor doesn't cover you at, and you contact your advisor to do follow-up on a patient that was under a different agency, you could get your advisor totally canned.
That's good to know.
Because now you've asked me to go look up a chart
That you
on a
had no
patient
involvement
I
with.
have zero involvement with.
Yeah.
And I don't cover you at that other agency. I'm not the advisor for that agency. And I just accessed a patient's private medical record. You've killed me. Yeah. Yeah.
That's good to know.
Yeah.
It's good thing not to ask. Yeah, even
Yeah.
if you're friends with them, right? Don't put them in that
Yeah.
situation.
Oh, never.
Sometimes it's just not, you don't get to know. And I think people as humans, we struggle with that.
Yeah.
There are some questions that you're not going to get an answer
Well,
to.
now I walk away from each shift like I have no idea.
Yeah.
But you know what? I showed
Get
up and I did my
comfortable
job.
in not knowing. Yeah.
Well, I mean, I think it still stands. I mean, when I was in training years ago, the most common diagnosis out of any emergency department on average is abdominal pain undifferentiated, meaning the patient's stomach is hurting and we don't know why.
Yeah.
And that's after blood work and CT scan and all sorts of stuff, and we still don't know why.
But it's not killing them. Because if it's killing them, you're
For
probably
the
gonna
things we
know.
checked, we don't think it's
Yeah.
killing you.
Yeah. Okay. That's fair.
Good luck.
Come back when you get worse. Yeah.
Exactly.
Yeah.
And they're really happy because now they just waited 9 hours and they got a huge bill, and
And they might have to come back in
and
6
some
hours.
Dr. Dierks the moron can't tell them what's going on.
Yeah.
Yeah.
Well, Dr. Dierks the moron, it has been a pleasure.
Thank you.
It's
It's
been a
fun.
pleasure. I
It's a
hope.
good time.
Yeah. I hope you enjoyed yourself.
It's fantastic.
Yeah. Next time, maybe we've talked about your house again, the whiskey. Just
Possibly
get a little more
do
relaxed.
do
Maybe a little
whiskey
fun.
tasting.
Yeah. Maybe a trivia or something would be super
Oh,
fun.
trivia could be interesting.
Yeah.
I
You
would
could even
not-
have
I would
people,
not
our
fare well.
followers can submit. Oh,
That would be dangerous.
one more question here from Usboy. He says, "Do you get people who get kidney stones?"
A lot.
Yeah.
Yeah.
Very
Kidney stones,
common.
classic emergency.
Yeah.
Painful. Like one of the most painful things you can have. And I had a friend who she had a kidney stone and she also had delivered a baby in the past and asked her like, so which one's worse? And she's like, they're equivalent. It's just the kidney stone is like there and on right now, whereas the labor kind of came on gradually. But kidney stone, I've had like huge built police officers. I've had an NFL player who was like on the ground crying in the ER because of a kidney stone. So they are horrible. I don't ever want one.
And prevention, water.
Hydration.
Drink lots of
Hydration's
water.
good.
Lay off the energy drinks, right?
Yeah,
I've heard
it's
bad
not good
things
for
about.
you.
Yeah. Okay, well, that is the end of the show for today, but trust us, we will be back. Don't forget to check out our live lecture with Dr. Micah Dang, July 29th at 2 p.m. We will be live here on TikTok. We also stream those for our users on webinar, so where they can interact in real time. Unfortunately, the TikTok, when we do those, kind of hard to answer the questions because we're recording
Yeah,
them.
no
But
problem.
yeah, thank you guys so much, and everybody have a beautiful evening. Clear over here.
We're off here.
We make
Nice.
3 cents over here.
I can't wait to tell my wife. That's awesome.
Let's see.